All right, let's bypass the basics today and dive straight into this advanced clinical explainer. We're looking at a dense set of high-yield peer-to-peer integrations covering third trimester hepatic catastrophes and complex hemolytic conditions. Let's get right to the clinical data. We're starting with the pruritic onset of intrahepatic cholestasis of pregnancy, or ICP. Now, this condition is strictly defined by estrogen-induced biliary stasis. What you're actually evaluating here is a massive toxic accumulation of serum bile acids. And crucially, this happens entirely without biliary tract dilation, which is exactly how you immediately differentiate it from obstructive pathologies like choledocholithiasis. The clinical signature for this is highly specific. Your patient is going to report an intense, intractable pruritus that strictly localizes to the palms and soles, and it severely worsens at night. But here is the absolute key for your physical exam. There is strictly no primary rash. If you're seeing primary dermatologic lesions, you're almost certainly dealing with pup-pup, not isolated ICP. So why does this matter? Well, it's all about the discrete management steps dictated by the underlying pathophysiology. The mother generally remains hemodynamically stable and synthetically intact, but those high-level serum bile acids cross the placenta, creating a catastrophic risk for sudden intrauterine fetal demise. Because of that severe fetal threat, you have an absolute management protocol. You must strictly administer ursodeoxycholic acid to increase biliary excretion, and you strictly schedule delivery at 37 weeks to mitigate that terminal risk. Let's assess a clinical scenario to see this in action. You have a 32-week pregnant patient presenting with severe nocturnal palmar itching that's keeping her awake. Her exam shows absolutely no rash, labs reveal normal coagulation panels, but totally elevated bile acids. What is the exact appropriate next step in management? This scenario dictates an absolute management step. You have to select ursodeoxycholic acid administration. Let's break down exactly why the other options fail. Reassurance and topical corticosteroids? That completely fails to address the underlying severe risk of fetal demise from systemic bile acid toxicity. Antihistamines provide minimal symptomatic relief and do absolutely nothing to lower that toxic bile acid load threatening the fetus. Emergent delivery at 32 weeks carries excessive risks of extreme prematurity. Delivery is strictly scheduled for 37 weeks alongside UDCA. And a liver biopsy? That's excessively invasive and entirely unwarranted for an ICP diagnosis that's based on straightforward clinical and laboratory findings. So, ursodeoxycholic acid is the definitive correct target because it actively increases biliary excretion, lowering those maternal serum bile acids and protecting against sudden intrauterine fetal demise. All right, transitioning to our second module, let's look at how things build into true metabolic collapse with acute fatty liver of pregnancy, or AFLP. Pathologically, this is driven by a maternal fetal defect in fatty acid oxidation. This exact defect causes rapid microvesicular fat infiltration of the liver, leading directly to an abrupt and frankly catastrophic hepatic failure in the third trimester. Now, unlike the isolated pruritus of ICP we just looked at, AFLP drives a rapid systemic metabolic collapse. It is completely defined by a fulminant triad: profound hypoglycemia, severe coagulopathy, think prolonged PT and PTT that often progresses to DIC, and profound hepatic encephalopathy resulting from unregulated hyperammonia. The focal point here is the obstetric absolute fatal. Because the liver is actively in microvesicular failure, there's absolutely no medical therapy that will reverse this pathology while the pregnancy continues. Therefore, immediate maternal stabilization and emergent delivery are absolutely mandated, regardless of gestational age. It's the only way to halt the systemic collapse and prevent simultaneous maternal and fetal mortality. As a clinician, you must cleanly separate these two entities. Let's isolate the variants. ICP preserves synthetic liver function. Glucose and coagulation profiles stay perfectly normal, and it's managed with UDCA and a 37-week delivery. AFLP, on the other hand, completely destroys synthetic function, presenting aggressively with massive hypoglycemia, profound coagulopathy, and altered mental status. Your management completely hinges on recognizing this exact clinical divide. Applying this variance, let's evaluate a 36-week pregnant patient who presents with sudden onset jaundice, confusion, and abdominal pain. Her lab studies reveal a blood glucose crashing to 45 milligrams per deciliter and elevated PT and leukocytosis. Which of the following is the most appropriate next step in management? This presentation forces a strict clinical requirement: immediate stabilization and emergent delivery. Expectant management with continuous fetal monitoring simply guarantees maternal and fetal mortality because this patient is actively in fulminant hepatic failure. Administering ursodeocholic acid treats isolated bile acid toxicity, that's for ICP, completely missing the severe microvesicular failure and metabolic collapse of AFLP. Giving intravenous dextrose and observing temporarily treats the low glucose, but completely fails to arrest the underlying catastrophic liver failure. Plasmapheresis isn't a primary treatment here. Delivery is the sole definitive management to eliminate the metabolic stressor. So emergent delivery is the exact correct answer. It is a true medical emergency requiring absolute immediate delivery to reverse the maternal-fetal metabolic collapse. Let's move to our third module and analyze paroxysmal nocturnal hemoglobinuria, or PNH. Pathophysiologically, this is an acquired hematopoietic stem cell mutation. It's driven by an absolute deficit of the GPI anchor, and this mutation strictly results in the absence of protective CD55 and CD59 surface proteins on red blood cells. Without these protective proteins, complement kinetics just run completely unchecked. The complement system actively lyses these unprotected red blood cells intravascularly. This dumps massive amounts of hemoglobin directly into the urine, which concentrates heavily overnight, producing that classic presentation of morning hemoglobinuria. You need to memorize the exact triad for PNH: hemolytic anemia, pancytopenia due to the stem cell defect, and a severe hypercoagulable state. The highest yield red flag here is atypical venous thrombosis, specifically intra-abdominal presentations like Budd-Chiari syndrome. Because of this distinct mechanism, the diagnostic absolute strictly requires flow cytometry to physically confirm the absence of CD55 and CD59. You must clearly delineate PNH from frequent clinical mimics like autoimmune hemolytic anemia. Let's isolate the variants. PNH is strictly Coombs negative, features distinct pancytopenia, and traps the patient in a severe hypercoagulable state with intravascular hemolysis. Conversely, AIH is Coombs positive, presents with spherocytes on a peripheral smear, and is primarily a process of extravascular hemolysis driven by autoantibodies. Let's test this integration. A 31-year-old male presents with profound fatigue, dark urine that is worst in the morning, and new onset severe right upper quadrant abdominal pain. Imaging confirms a hepatic vein thrombosis. Direct Coombs testing is negative. Which of the following is the most accurate diagnostic test for this patient's underlying condition? This case demands a strict diagnostic pathway. A direct Coombs test is incorrect. It's already negative in the prompt. Plus, AIHA wouldn't typically present with atypical intra-abdominal thrombosis or morning hemoglobinuria. A peripheral blood smear for schistocytes indicates microangiopathic hemolytic anemia, which doesn't fit our specific triad of morning hemoglobinuria, pancytopenia, and atypical thrombosis. An osmotic fragility test diagnoses hereditary spherocytosis. That features extravascular hemolysis and splenomegaly, not severe intravascular complement destruction and thrombosis. And a bone marrow biopsy is unnecessarily invasive as an initial diagnostic step. Even though PNH involves a stem cell mutation, peripheral blood flow cytometry is the gold standard. Therefore, flow cytometry for CD55 and CD59 is the definitive correct answer. The patient exhibits the classic PNH triad, which is definitively diagnosed by demonstrating the absence of GPI and carried proteins. That concludes this clinical explainer.